Welcome, everyone, and we're back to CLOT Conversations, the podcast where we explore the latest research and clinical insights in thrombosis. I'm David Airdrie, Executive Director of Thrombosis Canada, and I'm joined by my co-hosts Jamil Abdurrahman from Toronto General Hospital and Maha Othman from Queen's University in Kingston. Today's episode focuses on a highly practical and frequently encountered challenge in thrombosis care: how to manage anticoagulated patients undergoing planned surgical or procedural interventions. We'll be discussing a recent guidance document from the ISTH SCC Subcommittee on Perioperative and Critical Care Thrombosis and Hemostasis, which proposes a standardized approach to procedural bleeding risk stratification and published in the Journal of Thrombosis and Hemostasis.
Dr. Douketis is a staff physician in general internal medicine and clinical thromboembolism at St. Joseph's Healthcare Hamilton. He's a professor of medicine and holds the David Brayley Nancy Jordan Chair in Thromboembolic Diseases at McMaster University. Dr. Douketis is past president of Thrombosis Canada. Dr. Douketis' research interests include perioperative antithrombotic therapy, prognosis of patients with venous thromboembolism, hormone therapy and thrombosis, prevention of venous thrombosis in medical patients, and clinical practice guideline development. Dr. Joseph Shaw is a hematologist and thrombosis medicine specialist whose clinical and research work focuses on perioperative anticoagulation, anticoagulation reverses, and thrombin generation. He is associate scientist at the Ottawa Hospital Research Institute, an assistant professor at the University of Ottawa, and co-chair of the ISTH SSC on perioperative and critical care hemostasis and thrombosis. He's also a co-principal investigator of PAUSE2 alongside with Dr. James Douketis and principal investigator of ACE-HIGH. Thank you both for joining us today.
Thank you very much for having us.
Yeah, thank you.
Okay, so we'll get started with the questions. So why was it important to create a guidance document on periprocedural anticoagulation management for elective procedures?
Well, to start us off, Jamil, we all know that this is a common problem that pretty well affects every specialty in medicine and dentistry. So it's really germane and relevant to a broad spectrum of clinicians. And this is also a problem that arises very frequently. You may get a call from your dentist about what to do with extractions, or you may have a complex cancer surgery case that you need to manage patients' anticoagulation. And it's important to develop a starting point to classify patients in terms of the bleeding risk, because this will dictate to a large degree how you deal with your anticoagulation before, and perhaps most importantly, after the surgery in terms of the interruption and resumption periods.
Okay, great. So there's several guidance documents in the past. How does this guidance document differ from previous papers on periprocedural anticoagulation management, and how does it address the limitations of prior schemas?
What this adds to the literature, and more importantly, how this is intended to help clinicians, is that previous guidance on risk stratification was not as detailed and was kind of more broad brush strokes. Moreover, different societies had different and sometimes even contradictory classifications of how patients are determined in terms of their bleeding risk. So where this fits in, what this adds to the literature and hopefully will help clinical practice, is kind of like a very comprehensive approach to dealing not only with different specialties, but drilling down within each specialty. And Joseph will mention how that unfolded. But overall, it's meant to be kind of your one-stop shopping for how to classify patients in a variety of specialties, in a variety of procedures according to their bleeding risk. That, again, in turn will dictate how to manage patients around their surgery or procedures with their anticoagulants.
Dr. Douketis, and thank you for that. And I just want to add as well that some of the issues with these prior guidance documents or prior risk stratification schemas is that a lot of the time they were sometimes based on quantitative thresholds. So usually a quantitative number for the risk of bleeding. But the issue with the underlying data that supported those thresholds was often that These studies use different bleeding definitions, different follow-up windows, and a lot of this data was not necessarily limited to anticoagulated patients. And so whether or not it would actually apply to this patient population of interest is unclear. And so we aim to be very pragmatic with this risk stratification schema, pragmatic in the sense that it's based on more of a conceptual focus in terms of bleeding risk. So we thought more about pragmatic issues like volume of bleeding, whether bleeding is controllable intraoperatively, what would be the consequences of bleeding. So, for example, a small bleed can be trivial in one setting, but serious when bleeding is involving the airway, the eye, the spinal canal, for example. A lot of the revised guidance is more focused on that pragmatic aspect rather than what was probably fairly arbitrary bleed risk estimate cutoffs, for example.
Perfect. Thank you.
Okay, could you please now give us a brief overview of how the guidance in this document was created?
Yes, yeah, I can answer that question for sure. We tried to combine the best available literature and practical input from proceduralists who actually perform these procedures. So the process started with a structured literature search and a structured narrative review. So just like any other type of systematic review, we search databases for contemporary guidelines and review articles with procedural bleed risk stratification schemas with a focus on anticoagulated patients. We also integrated existing schemas that were used in major perioperative anticoagulation studies like the Bridge trial, the PAUSE study, and the Periop2 trials, which a lot of our listeners are likely familiar with. We took that information, it was abstracted, tabulated, and then compared across specialties and documents. And actually, in the final publication in the supplement, you'll see the actual Excel files that we use to compile all of this information. And it's directly available to readers in case they want to look at it themselves. From this information, we created a draft risk stratification framework, and then we circulated it to specialists from a wide range of procedural areas. And this included interventional radiology, gastroenterology, cardiology, anesthesia, general surgery, urology, orthopedics, OB-GYN, plastic surgery, ENT, dermatology, dentistry, and ophthalmology. So we had pretty much the whole range of surgical specialties that are often involved in these types of clinical scenarios. And these specialists then reviewed the procedures and provided their input in terms of whether they agreed or not. And then if there were any disagreements, these were resolved through discussion and a consensus process. So the idea is this guideline reflects both the existing literature, but also reflects the opinions and expertise of specialists who do these procedures every day.
Right. So, how should clinicians divide peri-procedural bleeding risk into practical framework?
So the framework that we're using, it mirrors the prior framework. So this guidance document is actually an update from prior procedural bleed risk stratification that was published in 2019 by Dr. Spiropoulos and Dr. Douketis as well. So we kept the same framework where we divide procedures into minimal bleed risk, low to moderate bleed risk, and high bleed risk. And the reason that we use this framework is that it has anticoagulation directly in mind. So each of these categories has direct implications in terms of what you do with your anticoagulation therapy. And the overarching idea is that minimal bleed risk procedures, generally speaking, can be performed without interrupting anticoagulation. In some cases, you might want to skip one dose of a DOAC, for example, on the morning of the day of the procedure. But generally speaking, if you were to continue anticoagulation, that was felt to be reasonably safe. Low to moderate bleed risk. So these are procedures where anticoagulation interruption is needed, but that a small residual anticoagulant effect is generally acceptable. Whereas high bleed risk procedures, as the name implies, these are generally procedures or extensive surgery with more tissue injury, bleeding that's harder to control, or it could be even a small amount of bleeding, but it's in a consequential location like CNS bleeding. And so these procedures, we usually recommend a longer interruption interval and little to no residual anticoagulant effect at the time of the procedure. So, again, the idea here is that although this gives you a general idea of the bleed risk itself, really it's inherently linked to anticoagulation management and what you do with your blood center therapy.
Okay. So for low, moderate, and high, you mentioned anticoagulation interruption. Could you give us a bit more detail with DOACs, how that would work?
Yeah, so a lot of this management, maybe Dr. Douketis, you can add to this, but a lot of this is centered around data that we have from the PAUSE study, which really defines mostly how we manage DOAC anticoagulation perioperatively. I mentioned for minimal bleed risk, these are minor procedures where, again, you could continue the DOAC throughout. So that could be a very simple dental extraction, one or two teeth, maybe with some local hemostatic support like tranexamic acid mouthwash. Sometimes you can omit one dose. And then maybe Dr. Douketis, you can provide some input for low to moderate bleed risk and high bleed risk based on findings from your PAUSE study.
Sure. And just want to add to what Dr. Shaw Joseph mentioned that these are detailed guidance for a wide variety of procedures. So that's a major step forward compared to what was there before. But it is also meant as a starting point. So everybody will look at their patient and the procedure individually. That's what we want them to do. But there may be variations within even a patient or a procedure. But in general, when we consider patients at low to moderate risk, so this involves a large number of procedures like a lap chole or a lap hernia repair. These are procedures where a single day before and a single day after the surgery of interruption appears to be associated with a low risk for perioperative bleeding. By that, I mean in the 1 to 2% range. And if you're looking at a high bleeding risk procedure, let's take intracranial procedure or major orthopedic surgery, then it's a 2-day period off before and a 2-day period off after. So the summation, we try to keep it simple, is that you're 2 full days off for a low, moderate bleed risk procedure, 4 full days off for a high bleed risk procedure. But I can't stress enough that this is a starting point and there's going to be some variability because, for example, if somebody has greater than expected bleeding after a surgery, then the protocols that have been studied don't mandate that you have to start the anticoagulant, especially a DOAC, which, as we all know, act very rapidly in terms of their peak effect. And you can delay that by a day or two. So it assumes that there is effective surgical site hemostasis with these protocols.
So now I think it will be useful to tell us, how does management with low molecular weight heparin differ from DOACs in this framework, and what key elements should clinicians be aware of?
Maybe I can answer that question. So both low molecular weight heparin and DOACs share the similarity that they have a relatively fast onset of action and a relatively short half-life. I say relatively because I'm talking about in reference to warfarin, which, as we know, has a very long half-life and a slow onset of action. Generally speaking, therapeutic dose low molecular weight heparin is held for about 24 hours before the procedure. So Dr. Douketis had mentioned low to moderate bleed risk procedures. For DOACs, you usually skip 1 day. High bleed risk procedures, you usually skip 2 days. The main difference, I guess, with low molecular weight heparin is because the half-life is even shorter than DOACs, usually bleed risk doesn't really inform preoperative interruption. So what I mean by that is the half-life is so short that you can usually continue it up until the day before surgery. And we usually recommend giving a prophylactic or intermediate dose on the morning of preoperative day -1, regardless of whether the procedure is low or high bleed risk. So that's in contrast to DOACs, where you modulate your approach. You give a longer interruption interval for high bleed risk procedures with DOACs to allow the anticoagulant effect to wear off. Where low molecular weight heparin differs in terms of bleed risk is for postoperative restart. So generally speaking, if it's a low to moderate bleed risk procedure, you should be okay to restart therapeutic dose low molecular weight heparin 24 hours after the procedure. Whereas for high bleed risk procedures, usually you'd want to wait 48 to 72 hours to make sure that you have good hemostasis before restarting that low molecular weight heparin, because similar to the DOACs, it does kick in. The onset of action is usually 2 to 4 hours. And so you really want to make sure that you're confident there's no residual risk of bleeding when you're restarting. But an important caveat here is that with the low molecular weight heparin, and even with the DOACs, when we're saying a restart, we're talking about the full therapeutic dosing. However, you don't want to forget about standard VTE prophylaxis. So let's say that you're aiming to restart full dose on day 2. that doesn't prevent you from giving a low dose prophylactic dose of low molecular weight heparin on postoperative day one, as you would with most other procedures for VT prevention purposes.
Okay, great. So this document addresses periprocedural anticoagulation specifically in adults and may not apply to pediatric populations. What considerations need to be taken into when addressing periprocedural anticoagulation in the pediatric population?
Yeah, so I think that's an important limitation. I'll start by saying that all of the data that informed this revised risk stratification really was our search was limited to adults. And so all of these risk strata that we use to then create this amalgamation is mostly based on adults. The guidance as a result was developed for anticoagulated adult patients undergoing planned elective procedures. And again, these bleeding risk schemas identified in the literature were all adult focused. The reason that this is in the guidance document is that it was raised during the review process that there's very little data for pediatric patients on this particular topic. And so they were wondering whether we could make a comment on whether this could be extrapolated to pediatric patients. We said that it's reasonable, but there are some very important caveats that need to be considered. So, as we all know, children differ in anatomy. The procedures might be different in terms of the techniques that are used. Children have evolving physiology, specifically as it relates to hemostasis as they get older. So coagulation in a 1-year-old patient is not the same as in a 12-year-old patient, right? So along with that, there's differences in anticoagulant clearance, dosing, monitoring that can all differ by age and developmental stage. And so the idea is that the same procedure as well may not have the same bleeding implications in a child as in an adult. On top of all that, there's important psychosocial issues. So pediatric decisions often involve parents and caregivers, proxy consent. There may be family stress related to the risk of bleeding and the child's psychological experiences. So we wanted to make sure we were framing all of that and emphasizing those particular issues where really in adults, they're not necessarily as prominent. The idea is that this framework can inform thinking, but this isn't a pediatric guideline and it's not really specifically designed for pediatric cases. So it needs to be used fairly cautiously.
Okay.
So, in the guidance document, I think it was very clear that you were careful to advise that risk stratification does not dictate management. Could you comment further on this, please?
Yeah, Jim, you already touched on this a little bit. I don't know if you want to take this question.
I think the point I was trying to make is that this is not a kind of recipe that's to be followed by to the letter, and it's meant as a starting point. And I think in the vast majority of cases, it will work. And in support of this, we had, as Joseph mentioned, a lot of input from surgery and procedure specific specialists to ensure that, okay, if we're dealing, let's say, with the GI procedure, or colonoscopy that's routine is going to probably be low, moderate risk, or even minimal risk if very few, if or any biopsies are going to be done. Whereas if it's involving potential polyp resections, especially larger ones, and then, you go into the high risk category, there has to be, it kind of forces, if you will, the clinician to say, oh, okay, I'm dealing with my patient and how do they fit into these categories are a little bit different. And sometimes you just have to have a discussion with the surgeon or the proceduralist because maybe they've had a history of bleeding with routine procedures and you need to adjust. So it provides a framework to start the discussion, but sometimes you'll need to reach out to the proceduralists. And I do this often in my practice when I'm not sure. And I think it helps reduce stress, not only for the team, but of course, let's not forget the patient that they just want to get through it and be done with it safely and without much to do.
Yeah, I'll just add to that this concept that risk stratification doesn't dictate management was really central to the guidance document because this comes up all the time. Both myself and Dr. Douketis were recruiting for various studies that involve having to risk stratify patients and then decide on an anticoagulant plan. And it comes up all the time where local investigators reach out to us and say, this procedure is listed as this, but I don't agree. I want to manage it as this. And that's okay. The idea, like Jim said, this is a starting point, but you also can't consider procedural bleed risk in a vacuum. You have to think about important modifiers like chronic kidney disease, thrombocytopenia, prior major bleeding. And as Jim also mentioned, some procedures, two procedures are really alike. Patients can have risk factors like obesity, adhesions, fibrosis, distorted anatomy. So a lot of this, again, comes down to making sure you're communicating with the surgeon. Sometimes that can be logistically difficult, but it is important to try and get a sense of whether or not there are any specific concerns for this particular patient that may modify that base risk stratification. But the tables are really they're just a starting point.
Yeah, I can also add, just from my years of experience doing this, I found that the surgeons or the proceduralists, they actually really appreciate it if you reach out to them and say, okay, we're going to do this. And you know what? We might anticipate a bit more bleeding given what you're going to do. And you'll be surprised how they can adjust their management when they're doing the procedure or they're in the OR. And they like that kind of advanced warning and they'll be able to adjust accordingly. So I think another key concept, as Joseph alluded to, whether it's through chat or just the old-fashioned way, is to communicate among the key members of that perioperative healthcare team.
Okay, well, this was very useful. How about now you take us through the day-to-day practice and how can decisions be made?
I'd say that the main change, as Jim alluded to, is that we're trying to move away from more vague categories like minor or major surgery to a more structured procedure specific process. And so I'd probably walk myself, if I were using this guidance document, I'd walk myself through four questions. The first being, what anticoagulant is the patient on and why? Meaning, what's their indication for anticoagulation? That helps to tell you how you're going to manage that particular anticoagulant, but also what is their thrombotic risk as far as decisions relating to bridging, which is only relevant for warfarin. And then you ask yourself, what is the exact procedure? And thankfully, now with these more detailed tables, most common procedures should be there. Maybe not every permutation of every single procedure, but it's definitely a lot more detailed than previously. So if it's a cystoscopy, is it a simple cystoscopy or is it something like a chirp or a prostate related procedure that may bleed quite a bit more? And then based on that, you can decide on what the bleed risk category is using the tables and classify it as minimal, low to moderate, or high. And then based on that risk stratification, you then want to think about these modifiers I talked about earlier, like was there prior perioperative bleeding, thrombocytopenia? Is the patient frail, for example? So we didn't talk about that yet, but something that was important to incorporate is psychosocial aspects, where if a patient is older and let's say that they might have what would otherwise be considered more minor bleeding, but they're not going to be able to manage it themselves, like put pressure on the incision, for example, that may also induce you to or push you to be maybe a bit more conservative with your interruption. And then I think another important part is to make sure that you're making the plan explicit and communicating that plan. The Jim talked about talking to the proceduralists, but I think documenting the plan very clearly in terms of dates of when to stop and restart the anticoagulation in reference to the procedure date and what to do if bleeding happens. And also to make sure you're communicating that plan very clearly to the patient. That's one of the benefits with the pause management for DOACs is that it's fairly simple and that makes it easy to tell patients what to do and communicate that plan to everyone involved.
Okay, thanks. So, what are the remaining knowledge gaps in periprocedural anticoagulation that still require further data? Maybe you could tell us a bit about ACE-HIGH or PAUSE2.
Yes, yeah. So I think the biggest gap that we highlight directly related to this guidance document, I mentioned it already, but it's that we don't really have high quality procedure specific bleeding estimates for anticoagulated patients. And if I'm being honest, we probably never will because there's an infinite combination of anticoagulant specific procedure. And then to get that data with a defined follow up, high quality data using outcome adjudication with a good definition, we're probably never really going to get it other than for very common procedures like EGD or knee replacements, for example. So I think that's an important evidence gap. And we got around that with this guidance document by focusing on being very pragmatic and hopefully being useful to clinicians. But I think outside of that, in perioperative anticoagulation research, We need better data in patients with active cancer, patients with chronic kidney disease, patients with very high thrombotic risk like mechanical heart valves, but also high procedural bleed risk. So these are the patients where clinicians are less certain on how to best manage them. And these are the indications for which we have very little data. So you mentioned the PAUSE2 study. Jim, I don't know if you wanted to talk a little bit about PAUSE2 and how it relates to all this.
What I first want to do is just supplement what you said, Joseph, is that, and the work that you're doing sort of informs this, is that we still don't have very precise ways to predict bleeding, and especially in a perioperative setting. And PAUSE2, for example, is looking at whether a residual DOAC level as a result of interruption of your DOAC for either, 2 days or like 60, 68 hours versus 3 days or 80, 88 hours makes a difference in residual DOAC levels. But, work that Joseph has done has shown that these levels don't necessarily predict bleeding. And he's also developing more sophisticated tests that are not widely used in clinical practice relating to thrombogeneration to see if we can adapt a precision medicine approach and say, okay, this patient, based on these test results, is maybe at higher risk for bleeding. So we need to be careful perioperatively. So those are going unanswered questions. And then procedure-specific areas. So Joseph's ACE-HIGH that have cancer, and these are particularly challenging patients, as we all know, because of their higher thrombotic risk, but also because of likely their higher bleeding risk. So if I were to summarize in one sentence, I'd say finding better tools, tests that predict bleeding, and secondly, getting more data in common but also challenging procedures. So data specific to those interventions.
Okay, so I think we've covered almost everything and the key elements on this guidance document. Is there anything else that we haven't talked about that you would like to add?
I just want to emphasize that some colleagues, and when they looked at this guidance document, it is a lot more detail and it's longer. So I think that I recognize that the new format, it's maybe harder to remember by heart. There's a lot of procedures across many specialties, so you're not going to be able to memorize all of it. But I do think you can take practical steps, like we're talking about printing the tables and pinning them in our thrombosis clinic here in Ottawa and building them into local protocols. But I think the point is not to remember every procedure, but it's just to have a structured place to look. And I think an interesting area would be trying to incorporate AI and large language models. Large language models are really good at handling large amounts of information and using these tools interactive. And you could see in the future how maybe there would be a way of having a portal where you're putting in, obviously no identifiers, but you're putting in your patient's information, like what type of procedure they're having. Maybe it's not even a procedure that exactly lines up with the ones that we have listed in the guidance document, but it could be similar. And then you would also mention the anticoagulant, renal function, antiplatelet use, any patient-specific factors. And I think AI has gotten to a point where it can integrate all of that information and maybe obviously not replace clinician judgment, but it could definitely act in a synergistic way to clinician decision-making to help standardize the thought process and help to organize all of this more detailed information that we're giving clinicians. So I think that'll be an interesting, maybe not overly scientific, but maybe a pragmatic way of helping to apply our recommendations.
And if you haven't already, make sure you download the Thrombosis Canada app on your phone, because all this information will be at your fingertips.
All right. Well, Dr. Douketis and Dr. Shaw, thank you both for joining us and for sharing these practical insights from this important guidance.
You're very welcome. Thank you.
For our listeners, we'll be including a link to the full publication in the show notes. And if you enjoyed this episode, be sure to follow CLOT Conversations so you don't miss future discussions or the past 52 discussions that we've had over the last couple of years. And don't forget to visit thrombosiscanada.ca for clinical guides, tools like our app, and educational resources to support your practice. Your support also helps us continue this work. Consider donating to Thrombosis Canada, and thank you for listening.